to Health System CIO's interview with Dr. Matthew Sullivan, CMIO at Advocate Health Southeast Region. I'm Anthony Guerra, founder and editor-in-chief. Dr. Sullivan, thanks for joining me.
Thanks for having me, Anthony.
All right, very good. We're putting together a little post-CHIME Fall Forum supplement. So you spoke at the show. I talked to you before about your session, and we got
Yeah,
into that in much detail. How'd that go? In terms of, and when I say how it went, I'm curious as to the follow-up after, so you got your attendance in the room, which is one way to gauge interest. Then you have sort of the post-session questions. And I think those can maybe let you know what people are thinking or where they're trying to drill down into your topic. Any thoughts there?
yeah. At first, the show was great. I was on a panel with a bunch of smart people and they're very helpful. And again, panels are great because you get a different reflection, sometimes around a very similar question. And of course, ours was AI focused around clinical decision support.
Mm-hmm.
And where's the next set of technologies going to affect the way we deliver healthcare? So I thought that was really a novel way to think through how we can apply new tech to an old problem. But that problem we haven't quite solved even using the old tools. So
Mm-hmm.
we've always talked about the 5 rights for clinical decision support, and then now with the FDA looking at AI and how that plays a role in clinical decision support. I thought the session was quite good, and I was pleased to be part of it. Um, you know, our approach was through FDB, and they sort of set us up well to help us really focus on the target. And I think Anna did a great job mentoring and sort of moderating this panel. And so we came away with a lot of pretty good questions after the session. Some of them exactly like you would imagine, sort of asking me what my crystal ball was. I don't have a crystal ball, but I certainly gave it a shot. I gave them my thoughts. But I think where you're going is, how does this affect us at large, and what was the downstream effect? Like, so what happened at dinner that night? Did the conversation keep going? Because I think that is the value of the meeting, right?
Mm-hmm.
It's to sit there and have some idea generation, some thoughts, some conversations, and then mull on it for a while. And then
Mm-hmm.
you go to, connect in 3 dimensions with other people around the dinner table or, at a reception and talk about, is this really affecting everybody? Is it a small segment? How are we going to do? How's it going to really change the landscape of healthcare? Are the costs going to come way down? If it's going to be heavy computing, are those computing costs going to go down over time? And is the technology going to get better over time? All those things come into play. And I thought that kind of was the springboard of the talk onto further conversations that we had throughout the week.
Cost is an interesting point. It factors into this whole thing, right? It's not just a bottomless pit of money, and we can have all the fun we want, and
Yep.
and and we can have soft ROI all over the place, right? I mean, that
Well,
that
you
that I
could,
heard come up a few times. Um,
yeah.
the idea of, we got to pay for this stuff, and the
Mhm.
CFO types, they don't love all that soft ROI.
No, they don't. And so I think the shift is going to be in the next year or two is that particularly startups and even vendors that we have had long-standing partnerships that are quite large are going to come to the table preloaded. They're going to say, here's what we provide, here's where the hard ROI is, and then by the way, we're going to also save you all this other funny soft money that we've been promoting forever. But I'm starting to see that. I had actually a couple vendor conversations where they were starting to come and think about how could we partner with you as a large healthcare system to deliver hard ROI, deliver value, and then all the soft stuff. Okay, yeah, you guys can keep that, because I think they're starting to understand that if they're coming to us with a technology solution that is designed to make us efficient, which is great. I'm not knocking that, right? If we make our physicians and our nurses more efficient, that's fantastic. We're not firing physicians or firing nurses as a result of us being more efficient.
Right.
What we're doing is we're allowing them to either have a little less ragtag lives because they're running around like crazy, or we're allowing them to see more patients, or, and this is rough, like we're allowing them to spend more time at the bedside or in the office with the patient, which I think is what all of us in the country are looking to go back to doing, spending a little bit more quality time with the doc, while all of our technology takes away stuff on the back end. people typing or people putting in orders or people, looking up stuff or trying to arrange appointments. If we can take care of that, then we're in business. I think we will start to see the joy of medicine come back a lot, but it has to be driven off the hard ROI. And I think we're going to see vendors come that way. So I'm glad you heard it. I heard it too. So we're aligned there.
Yeah. Uh, One of the other interesting, you mentioned the different ways that um, increased physician efficiency can go. It's one thing to tell a physician, we're going to make you more efficient and you get more pajama time, as we love that phrase, which is a big winner. I want more
Yeah,
pajama time.
less.
But if you say, hey, listen,
I think it's less pajama time, isn't it?
oh, well, what?
Yeah, lower. We don't want to. You don't want to be doing your job in your pajamas. I mean,
Don't want
maybe
to.
you do, but
Well, I meant it in the sense that they're in their pajamas, but not necessarily working.
okay.
So I
Maybe
guess
I got
it
it wrong.
depends how you define pajama time. Maybe that means no, but I'm sure you're right. But the idea that we're going to make you more efficient and you're going to have more of your time
Mhm.
versus we're going to make you more efficient so you can see five more patients a
Right.
day. Different. Those go over probably a little differently with physicians, right? I
Yeah.
mean,
Mhm.
is there anything there?
Yeah. I mean, I think there's a self-selection, right?
Yeah.
If you're a very efficient physician today, and you're seeing, a pretty full schedule,
Mm-hmm.
and you're tolerating that well, and you're not, burned out or whatever the right term is, if your resilience is high and you're tolerating this workload, and we give you a tool that lowers the workload a little bit, you're going to be pretty happy.
Mm-hmm.
But if we only lower your workload by a little bit, we can't force more into the like you're just forcing more onto the machinery. Now, if we give you a lot of time back and you're already one of those very efficient docs, you're naturally going to say to your office manager, yeah, sure, work that in. Oh, no problem. I'll see Mrs. Jones at 2. Yeah, work her in at 2 and I'll catch up and we'll do that, because you're that kind of dynamic, efficient, amiable physician.
That's a really good point. And if as a health system, you're saying, hey, let's invest in these technologies, and it's going to help us, financially. There's an upside. There's an ROI. Well, you have to, like you just explained, if you make them much more efficient and they can see a couple more patients, everybody's happy because the health
Everybody wins.
system, right? Because then the ROI makes sense. So, but like you said, the key is significant improvement
Yeah.
in, yeah. And then
And the
it's
judge,
a win-win.
like the judge is still out on that one. We don't
Yeah,
really know. We,
right.
we have not, the jury's still out. I guess you can be the judge and the jury.
The
They're
j-
both still out. We're mixing our metaphors badly here today,
Yeah,
Anthony.
we are.
So we've got a bunch of technology that's showing efficiencies, showing that physicians are happier in doing their jobs. We've got AI efficiencies helping tee up messages for nurses that are working the inboxes, and it's just really interesting to see, what does that mean?
Hmm.
It's definitely not. We're not getting rid of those people. We need those people, and we need more of them in many cases. And the supply is short. So, are we just stealing ourselves? Like really being ready for that true physician shortage that we've been talking about for the last 25 years? Maybe we are. Maybe that's the right approach. At the same time, it's pretty obvious to me that the physicians who are using advanced tools, whatever form you're talking about, they seem to enjoy them, and they seem to get the value. Now, do they want to change their lives around that? Probably not. Are they going to pay a lot out of pocket? Are we going to ask the physicians to pay out of pocket for these tools that are expensive? Probably not. Some institutions have to because they don't have the money to do it. But I think you're going to see a lot of people become a little happier in medicine. You're going to see a lot of people self-select to work in a different way.
Hmm.
I won't say work harder because that's probably the wrong way. Work
Yeah.
smarter.
Yeah.
I think that's where we are right now. We've early literature is out there. We've published some. Others have published great studies around tools that are coming. A lot of people talked about those at the Fall Forum. The answer is clearly we believe that cost for some of the supporting, computing power behind that is going to go down. We also think that a lot of the AI tool sets, the large language model, that kind of work is going to become better over time. That makes a lot of sense.
Hmm.
So then the question is, what will we look like in 5 years? And that's where a lot of these conversations landed. Where are we going to be in 5 years? And that's interesting to me.
Well, where are we going to be in 5 years? It's hard to answer, right? But can we answer what kind of technologies we need to keep playing with in order to be where we're supposed to be in 5 years? Right? And AI is one of them,
Right.
and these ambient things.
It is.
If we stay engaged with this stuff and build an agile framework around experimenting with it and using it, then we should be where we're supposed to be. Right? If we don't have a good framework to use this stuff and for our users to experiment with this stuff, then we're probably going to be behind where other people are.
Yeah.
Yeah.
And it's sort of like, the analogy is very similar to you go to a restaurant in the late 80s and there's a touch screen and they're using it. And you look around and go, how come I can't get that in my office? But they had those point of service, just, point of sale touch screens out where it made a lot of sense, faster than healthcare by a long shot.
Mm-hmm.
I don't want to be watching the rest of the world lead
Mm.
in AI with healthcare as a laggard. I don't think we will, based on what I've seen. I do agree with you that we need to be agile and try to figure that out. And I think there's going to be a handful of people that will be able to pull that off successfully, and really help the rest of the nation, because it's expensive, it's time consuming, and there's some risk to it.
Yeah, and healthcare, so about being agile, healthcare is not known for being agile with good
No.
reason, right? With good reason. It's serious stuff, and changes have to be vetted and all that. I remember reading an article by C.T. Lin, who's the CMIO, and he wrote about how if you want to change in workflow, you have to come ready with that request. You have to have your documentation and your research done, and you can't just come and say, "Hey, I have an idea," to whatever governance committee is involved.
Yep.
So there is an onerous, probably rightfully so, process to getting a change in a healthcare, especially a clinical workflow. And I wonder if you have any thoughts around the idea that in order to this stuff is going to change so quickly and it's got such potential, but it's almost like clay. Like it's going to change so quickly, and how to use it best is going to change. So if we have a very difficult process for changing workflows, it's going to be very difficult to sort of keep up. That may be inevitable, but there may be something to do there to help healthcare be more experimental and quicker to leverage these things.
Yeah, and we're actually looking to do that kind of work on a much shorter time scale. So there's two components, I think, to what you're talking about, which is sort of the time scale for iteration, the agile approach, if you will. And then there's the delivery mechanism, because you're delivering this downstream to the healthcare providers who are they're head down. They're actually head
Hmm.
down doing the work that doctors and nurses and ancillary healthcare providers of all types do. And not all of them have the willingness or interest or ability to pick up and go, oh yeah, let me learn something new, or oh, let me change everything real quick. So we've got to make that change that we've quickly iterated on. That change has to have value, and then we have to be able to deliver that value in a very seamless way, so that it's not a huge shift. um, I don't want to get into vaccination, but as the influenza shifts around or drifts around, if it shifts massively, well, then we have a big flu outbreak. But as it drifts a little bit, we can tolerate that pretty well.
Hmm.
And I think we need to drift a little bit. And I think we've seen companies do that in the non-healthcare space well. We always refer to cell phone providers being the ones that when they change something on your cell phone OS, it's pretty intuitive. We need to
Yeah.
get to that point as well. So we'll look to Epic and Oracle and other big vendors in this space to help us become a little bit more innovative in the way we deliver education and changes in the EMR, so that these new technologies that we're trying rapidly to cycle through are delivered in a smoother, faster way, and it doesn't require somebody to spend a ton of time reading. Because if you're making people more efficient and you're saving them 15 or 20 or 30 minutes at a time in a day, don't take that time away from them and force them to read for 30 minutes in order to be able to use the tools tomorrow.
Yeah, one session I was in at the show, they were joking about tip sheets. They were saying Don't do no more tip sheets. We
Yeah,
don't want any
it's
updates
hard.
or an update or to have you shouldn't need a tip sheet, right? Because
Yeah. Should be pretty intuitive. At the
right.
same time, we don't want all of our providers to not like we don't want to turn around. So I have a I have a great example. I was having a conversation with a physician and gosh, they were telling me how great it was that the technology we put in. Oh, I love this. I love it. It's changed the game. It's going to be great. We've done all this stuff. Now all I need is something to do this. And I nodded, I listened, and I said, you know, that second part, we've had that available in the system for about 18 months. And he said, oh, wow. Thank you. And he, whoop, turns and takes off. I'm
Mm-hmm.
like,
Mm-hmm.
I don't want to have that experience anymore. I want it to be
Yes.
intuitive. I want everybody to understand, but it's really a very tough balance to strike.
Yeah, because that's absolutely not what you want to hear. Because then
Mhm.
you go where there's somewhere there was a gap in our
Uh-huh.
process, right? Because
Yep.
we did a great thing, somebody needed the great thing, but the fact that we did the great thing never got to them. So how do we fix that?
No, he got the great thing. He thought that there was a second part, but we did the second part a year and a half ago.
Right, right. So
And
why
it's like,
didn't he
what
hear about
happened?
that
And
second part?
now, yeah,
Yeah.
the building blocks, you know, he's admiring the second floor, realizing that he somehow got there on the first floor he missed.
Well, he'll get there. He'll get there now. Outside of some of the stuff we're talking about, or just, not figuring it in, your plans next 6 months, anything you're looking at focused on projects, initiatives, trends, anything that come to mind that is going to be high on your list of things to pay attention to?
I mean, I think the role of the CMIO is always to pay attention to the organization, and our organization is large and growing. So I think that we're going to see in the next 6 months a change in the healthcare system. We'll adapt to those things. That's one of our jobs. The second thing is the handle on AI. I think we spent a lot of the time
Yeah.
talking about that. There's going to need to be a really good rational approach to how do we deliver this stuff in a cost effective way. So I think that's pretty, I think that's a fairly generic answer that most people would say. And I think we're going to see, certainly I'm focused on using the tools that we've paid for at their
Mm.
absolute, like the optimum level. So if you've got a large EMR, you should be using every bit of it. If you're not using every bit of it, I think my focus then will be to go back to the EMR vendor and say, you've built this awesome jalopy. No one's driving it. How come? And it's hard when maybe the approach is different coming from a computer programmer than it is from a clinician. Somewhere in the middle, we're going to get there and we're going to find a better way. Because I do think there are some things that remain clunky. And I think we can smooth some of those pieces over. And I think I'm fortunate that we have a fairly good team, a fairly large organization, and we're pretty high performing. So when we walk back and say, hey, everything, look at all this, 90% of this we're using really well. This 10%, that's where we need to focus. Can you help us? I think we're going to get traction there.
All right.
That and all the basic stuff that comes with healthcare reform at a government level and trying to take care of large patient populations, that's everybody's goal. So I'm looking forward to it.
I'm going to ask you one more question, and you can handle this however you want. It's because you mentioned the large vendor. We know we've all everyone's got the large vendor. Where do you stand on this concept of vendor capture? And I don't know if that's a common term or it's just in my head, but the idea is that if you are too tied to staying in suite, your innovation is sort of beholden to your large vendor. You're just waiting for their roadmap and you wait for them to put things out, and you don't have that sort of more agile, nimble niche vendor pops up and they're amazing, right? It's amazing niche vendor and they do amazing things that our enterprise vendor doesn't have yet, or they've got a product but it's not as good and people want it, right? So there's clamoring from the clinician side, but there's huge efficiencies to staying in suite and continuing with your enterprise vendor. But then you give up perhaps some innovative juices on that. I've heard some strong opinions expressed on this concept, usually probably from people who are not managing the IT of a health system and want everyone to be innovative and more nimble. I don't know. Any thoughts around that?
Yeah, I mean, we've had this conversation for a long time, Anthony. This is build versus buy is another way to term this. Oh, we should build this we got people. And yeah, we probably could build lots of things. We can't maintain them very well. We won't be able to adapt to the, ever-changing governmental, cycles. So there's pitfalls to each. As it relates to being innovative, I think you should carve out two components. There's an innovative side of the organization, and then there's this is what we got. This is the Ford. You can have whatever color you want as long as it's black. To be honest with you, a good chunk of the work that we do is managed very easily through standard tools. So it's on the fringe cases where we're trying to do something innovative with patient care, quality outcomes. It's on those fringes that if we have the time, energy, and focus, we can actually do better. There are countless examples of where we have niche products that are in place that eventually, when that large vendor sees them, they realize, we should focus on that. And maybe because they're a behemoth and they have thousands of programs, boom, they can close that gap in 18 months and great. The downside risk of that is that you're stuck in a contract with a niche vendor and you got to wait, and now you're kind of almost double paying. But on the flip side, sometimes that time frame is 5 to 7 years, depending on how the larger vendors are having to respond to the rest of the world, not just you. And so I think there's a component of innovation that has to be there. Otherwise, you won't be able to solve the problems that are in your neck of the woods. And I think that I say all the time, I'm talking out of both sides of my mouth. Physicians generally see the same stuff everywhere. It's the same medicine, it's the same group. But the niche things, there are certain things, even in our large healthcare system, that are different in Georgia than they are in Charlotte, than they are in South Chicago. That's okay. We may be trying to find something that solves just one of those components. And we may have to do something really innovative to do so. The larger vendors are going to try to solve it for the world, and that's a different task. So sometimes that Venn diagram overlaps and you paid a vendor for a little bit longer than you should have, or you got to get out of contract and you didn't need to. I think people are understanding that. If we're signing a 1-year contract with you, you better look around.
It's such a crazy, it's such a wild situation, and it happens with Apple too. The example that's always in my mind is how before they put flashlight standard on your iPhone, it was one of the options in the App Store, so you could pay for it, right?
Yeah.
And I probably did pay for a flashlight app back in the day.
I did.
And then once once Apple's large eye turned to that, all those people went out of business. Nobody paid for a flashlight again in their life. So it's a wild place to be as a vendor. You don't have to answer if you don't want to, but the concept is you're a vendor, you find this niche, right? And you say, the behemoth isn't playing here, and we could play here, and we can make something really cool and innovative. And they do, and they get some customers, but as soon as the behemoth casts its eye on that niche, they can just laser those. It's crazy, right? And so, but that's the way it is. If the behemoth makes something as good or better, everyone, it's a game over.
That's right. I guess the analogy that I would throw out, and maybe this is where we end, is, Anthony, do you have a pencil sharpener somewhere in your house?
I do.
And the question is, what kind of pencil sharpener do you have? And how often do you use it? And are you willing to buy like the awesome pencil sharpener? So I have like this really compact, spring-loaded, high-tech Japanese pencil sharpener that I grew up with because I grew up in Japan. And it'll sharpen that thing to like a John Wick's sword kind of sharpness, right? Other people don't use a pencil and they got this little square box and they find it somewhere in a drawer and they just grind it out and they get just enough that pencil is functional in the kitchen drawer for another 6 to 8 months. And other people have abandoned all of that altogether and gone with only mechanical pencils. And so to me, that also explains healthcare. There are those people who are mechanical pencils, and there are those people that have an awesome pencil sharpener because they need it or want it or had it in the past and still maintain it. And there are those people that have a small, tiny chunk. It's thrown in the drawer somewhere, and if they need it, they'll find it. And if not, they really don't care. And that's sort of the right analogy in my brain.
Well, of the different vendors, of the
Of
different,
the different
yeah,
vendors,
yeah.
and in the end, the behemoth is making pens,
Making
or
pens.
styluses.
Listen, I think I got a little lost at the end with the pens and the
Yeah,
stylus, but
yeah, but that's okay. You're
we
with me.
covered that. We covered pajama time and
We're
something
in
about
trouble.
the judge and the jury.
I think so. The
So we
jury's
really
gone.
covered it. Dr. Sullivan, what more can we do? Thank you so
It's
much
great
for
to
your
talk
time
to
today.
you. Appreciate
Take
it.
care.
You too.